Discussing retinal degenerations can be very interesting. There are different presentations ranging from the clinical presentations where the patient would come up to you and give you a history of a visual disturbance. Again, the typical features that are compromising or that are pointing out towards a retinal degenerative problem are the floaters and the flashes. So these are the typical historical questions that the clues that the patient would give you in the history. So it's again very important to concentrate upon these kind of symptoms when the patient clinically presents to you with a visual disturbance, as well as the floaters or the complaints of the flashes in the visual field. That is again a very major clue towards the retinal degenerative problems. There are two basic terminologies that we usually clinically use or evaluate. One is the degeneration, and on the other hand, we have the dystrophies. What is the major significance difference that is underlying between the degeneration and the dystrophies is usually their incidence. Dystrophies are usually hereditary and congenital in incidence. On the other hand, we have degenerations that are again a variety of sometimes, and most importantly, they are the acquired conditions. So there is a difference between the dystrophies and the degenerations. These two terminologies are quite frequently used. Sometimes there is an overlaying mechanism in the clinical picture of both of these conditions. Either they are the dystrophies or either they are the degenerations. Again, it's very difficult to clinically discriminate between these two kinds of conditions. Now over here, we are going to see that the retinal degenerations, as you can see, it can be classified into different varieties. The classifications is sometimes based upon the mapping of the degenerative problem, or again, it can be the extent of the problem that it is causing. So over here, as you can see, it can be the peripheral retinal degenerations on one hand. Then we have the macular degenerations, and on the other hand, these macular degenerations can again be subdivided or sublimed into the age-related degenerations. On the other hand, we have the myopic macular degenerations. The causative factor for the macular degeneration, macula, as you all know, is the area that is responsible for the most central vision in a person. So if it is affected due to this degenerative problem, it is going to affect the central vision of a person rather than the peripheral vision in an individual. So this would be the common complaint of the individual, that the central vision is affected, the visual acuity lying in the most center is affected. Using an Amsler grid charting mechanism or any other mechanism by which you can basically relate to these scotomas or visual field effects, you'd evaluate that this particular patient is suffering from a visual field effect which is placed quite centrally. Again, what is causing these macular degenerations? On one hand, we have the senile problems. That is, the normal aging mechanism can sometimes result in this kind of a macular degenerative problem. On the other hand, a high myopic value or short-sightedness is sometimes one of the major causative factor towards the development of this macular degenerations in these a lot of people. Then we have the vitreoretinal degenerations. Now, apart from just involving the retina, it's sometimes the vitreous or the posterior chamber that is involved. Just by visualizing the normal anatomy of the eye, you'd remember that there is a posterior chamber that is lying quite in close relationship with the retina, that is the neurosensory or the end organ for the vision. So again, if there is some sort of a problem or if there is some sort of a retinal detachment, that is again going to involve the vitreous or the posterior chamber of the eye in these individuals. So this is how basically we classify this particular retinal degeneration problems, ranging from we'll start off with the peripheral areas, then we'd go to the center, and then we'd move on to the, if it is involving the posterior chamber or if it is involving the vitreous. Involvement of the vitreous is the major causative factor for the development of the floaters and again the development of the flashes in these individuals, because these vitreous hemorrhages or any involvement of the posterior chamber is going to result in the floaters and the flashes in that particular individual. So the signs and symptomatologies would be quite relating to the area that is involved of the retina of the posterior chamber. Either it is the fovea, either it is the fovea centralis of the macula. All of these areas would have their particular symptoms that would be involved, of course. Any retinal degeneration will have its own complications as well. The most common complication is the retinal detachment, and the most important treatment would also be to treat this retinal detachment through PRPs, that is the pars retinal vitrectomies that are performed to treat these retinal detachments, as well as there are a lot of laser therapies that are provided for such kind of complications. So this would be the whole classification that we can give for the retinal degenerations. Then talking about the peripheral retinal degenerations, on a general note, you should know what would be the particular findings when we would have that ophthalmoscope in our hand and we are looking at the fundus of the eye. What would be looking at? What would be the signs that we would want to look for? The lattice degeneration is again very important factor. As you know, it's lattice is a word for a crisscross or a meshwork formation that is found out in the fundus of that particular individual. So this is one of the kinds of the degenerative problems at the retina that is occurring. We have this mesh-like network that is available, and this is basically known as the lattice degeneration, as you can see at the A side. Then we have the snail tract degeneration. It is again a variant of the latticework degeneration. It has that snow wool appearance, that cotton wool appearance that is present. And this snail tract degeneration is again going to emphasize on the fact that gave rise to the formation of the cattle trucking phenomena in the veins and the arteries. The blood supply is hindered, obviously, and this is again going to manifest or picturize as the snail tract degeneration or the snail tract presentation in these kind of variants. Then the word retinoschisis, it's again one of the very important terminologies used that is known as the retinoschisis. What is happening is there is this basically splitting of the sensory layer of the retina that is known as the retinoschisis. Now, where does this splitting occur? This splitting is occurring at the outer plexiform layer and the inner nuclear layer. So this is a level of the splitting that we talk about. This is again going to result in the complications of retinal detachments, although latticework degenerations or the snail tract degenerations can again result in the retinal detachments. Acquired retinoschisis, in which the splitting has already occurred, that would basically aid towards the development of the retinal detachment in these patients. Again, the visual field effects are quite prominent in these individuals. There are absolute visual field effects that are basically known as the scotomas in these individuals. So then we have white with pressure. Where is the pressure being applied on? It's applied on the sclera. The scleral indentation is going to give rise to this whitish presentation on the fundus, and that is again going to highlight that there is some sort of a retinal degeneration going on in that particular area, which appears white on the scleral indentation. This is not particularly related to the retinal detachment, and sometimes it can be in very rare cases, but usually it is not related to that. Then we have the focal pigment clumping phenomena. This clumping is due to the pigmentation at the chorioretinal layer. It can be a diffuse chorioretinal degeneration that is occurring, and that is basically resulting in this clumping phenomena in these individuals. There is this pigmentation that can be quite scattered and quite sometimes resembling to a condition which is known as retinitis pigmentosa. That is again one of the hereditary kind of the retinal degenerations. Then on the other hand, we have the diffuse chorioretinal degenerations, in which we have pigmentations that are coupled up along with the degenerative mechanisms in these individuals. Then we have the peripheral cystoid degenerations in a lot of individuals, and in these individuals, you'd like to appreciate the cyst formations at the neuroretinal layer. So these are quite evident, and sometimes they can be appreciated quite well if it is an advanced case of peripheral cystoid degeneration. Now, one of the most important degenerative changes that are occurring at the retina is the lattice degeneration that is occurring. It is the most commonly occurring retinal degeneration that is in talking about in terms of the incidence. It's almost 6 to 10% in the general population and almost 15 to 20% in the short-sighted people or in the myopic individual. This kind of the retinal degeneration is quite common in these individuals. As you can see, the most important occurrence or the incidence that is most prevalent in the individuals is the superior and the temporal location. So this is the most common location that we usually observe, that is usually superiorly located in the superior quadrant. Again, it's the temporal quadrant rather than the nasal quadrant, and rather than the inferior sites, the superior sites are most importantly or most prevalently located, or they are mostly exposed to this kind of the latticework degeneration. What are the features of this kind of a latticework degeneration? It can be the arborizing lines. If you can appreciate over here, these are the arborizing lines. Then there are sometimes the holes that are present in the retina. There are small holes that basically give way to the presentation or to the formation of the retinal detachment in these individuals. And then we have the spindle-shaped ora serrata. So as you can appreciate over here, ora serrata over here, it's quite different. As you can see, where there is the incidence of the retinal detachments, again, the spindle-shaped formation is present over there, or either it's quite in a stretched form that is basically giving way to the formation of this spindle shapes over there. So emphasizing, you'd start basically appreciating from the ora serrata. When you're looking at the fundus of an individual through an ophthalmoscope, you're going to start off with the periphery, and then you're going to move on slowly to centrally and just see what are the typical findings, or are these typical findings, are there any holes, are there any arborizing lines that are present in this kind of a retina or not. They are basically pointing out, cluing towards the formation of the latticework degeneration in these individuals. Again, the history would be quite typical in these patients. The patients would give you a history of a decreased vision. There would be a grayish hue that would be seen in the visual field of these individuals. Again, there can be the floaters or the flashes that are observed by these individuals. So these are the typical complaints or the typical presenting complaints that the patient would give you. And then you can appreciate, or you can diagnose, at least you can have a differential diagnosis in which you have the snail tract, you have the retinal latticework degenerations, you have the retinal dystrophies in those in the list of differential diagnoses that you have. Retinal detachment is being shown by this whitish hue that you can appreciate over here. The retina is somewhat, there is a thinning and the sheathing of the vessels that is noted down in the retina of these individuals. The vitreous is again going to be affected as well. There is going to be somewhat liquefaction of the vitreous that is somewhat noted down in these cases of latticework degenerations. Retinal tears or even the holes can be quite prominently seen in these individuals who are suffering from this kind of retinal degeneration. The characteristic features would be, again, as you would appreciate even over here, there are the retinal holes. As you can see over here, there are these arborizing lines. The ora serrata is spindle shaped. These hole and arborizations and the retinal degenerative mechanisms are basically pointing out towards the fact that this particular case is going towards the complications. The complications, again, would range from the retinal detachments and obviously all of the treatment modalities that are present out there to treat such detachments and to treat such degenerations would be particularly out there, and you can just concentrate on that. You can see that these are the lattice kind of degenerations that are observed. The meshwork that you can observe over here that is pointing out, that is basically giving way to the name or to the naming of this particular condition, that is the lattice work degeneration. Then the retinal holes are again one of the most common characteristic feature of this lattice work degeneration. Snail tract degeneration is another variant of the lattice work degeneration. It's again one of the most common variant, the snowflaking mechanism, or then we have the white frost appearance. That is the major characteristic appearance as you can see over here. The snowflaking appearance, as you can see, the whitish hues are basically the features that are basically giving the name towards this snail tract degeneration mechanisms. Snail tracking is sometimes basically referring towards the phenomena, the same mechanisms that are giving way towards the cattle trucking mechanisms in the veins and the arteries. That is basically the blockage of the veins and the arteries is giving way to this kind of the snail track presentations as well. One of the other variant of the retinal degenerations is the acquired retinoschisis. What is retinoschisis? It's the name of the name retinoschisis is basically referring to a condition in which there is a splitting of the sensory layer of the retina. The splitting of the sensory layer of the retina is occurring at the inner nuclear layer and the outer plexiform layer. If you just recall the histology that we'd already studied, we had the nuclear layer, we had the choroid plexus, we had the plexiform layers, we had the ganglionic layers, and all of these layers, we had almost 10 layers when we were studying the histology of the retina. So this splitting of the retinoschisis is particularly occurring at the inner nuclear layer and the outer plexiform layer. The complications towards this acquired retinoschisis would be obviously the retinal detachment. The visual field defects are quite absolute in this kind of the acquired retinoschisis phenomena. As you can see, as you can appreciate, there is this thinning of the transparent retinal layers that is observed in this acquired retinoschisis. This thinning is basically giving a darkened hue towards the retina on ophthalmoscopy or when you're performing the fundoscopy. Now, the location or the occurrence of this kind of the acquired retinoschisis is mostly temporal, but again, it's inferiorly located rather than superiorly located. If we give a comparison towards the lattice degeneration that we've already covered, that was mostly temporally and superiorly located. On the other hand, we have acquired retinoschisis, which is inferiorly and again temporally located. What are the causative factors towards this development of retinoschisis in the individuals? Usually, first of all, it is age-related. Senile mechanisms, they come into action. And that is basically making the formation of retinoschisis much more easier in these individuals. On the other hand, we have the high myopics. So again, myopia is one of the causative factors towards this development of the acquired retinoschisis, or towards the complications of the retinal detachments in these retinoschisis. Again, you can see it can be a congenital condition as well. Over here, we're just focusing on the acquired retinoschisis, but again, I'd like to emphasize in much rarer cases, of course, but still you can just keep in mind that it can be a congenital condition as well as in these individuals. So over here, you can just appreciate we perform a lot of ERGs that are performed for this acquired retinoschisis, and we see that there is an outer plexiform layer and there is a split at this outer plexiform layer and the inner nuclear layer that is observed on these ERGs. That are basically the advanced testing mechanisms performed for the diagnosis of the retinal splitting in these individuals. The splitting, as you can appreciate over here, these layers are quite adherent over here, but these are quite in a split form over here. So these are appreciated when you perform the ERGs in these individuals who are suffering from the acquired, or you are just being suspicious, or you have a differential diagnosis of acquired retinoschisis, retinal degenerations, retinal dystrophies at your hand, and you're just focusing on the fact what is the causative factor towards the decrease in the visual acuity in these individuals. Then the other variants that we'd like to move on, or we'd like to just briefly cover up, are the white with pressure and white without pressure, the retinal degenerations, which appear white when there is a pressure that is imposed on the sclera, or there is a scleral indentation performed. You would see that there is a white areas, there are white areas that appear on the retina of these individuals. This is the white with pressure. After performing the scleral indentation, you would appreciate that these areas of whitish appearance, they appear on the retina of these individuals. If they appear without the scleral indentation, they are termed as white without pressure in these individuals. The lattice work degenerations are sometimes in close relation with the white with pressure. These lattice work is sometimes hindered due to this whitish hue that is present, or that can be present on further, or that can be visualized on further investigations. But sometimes it is an overlapping picture that is seen in the lattice work degenerations and the white without pressure retinal degenerations in the individuals. We also studied one of the characteristic features of the retinal degenerations as the focal pigmentations of the clump, or the clumping phenomena. There are these clumps, these pigmentary clumps. It can be at the chorioretinal layer as well. So these clumpings or these pigmentary changes are sometimes noted down in the retina of a lot of individuals. They are quite peculiar, or sometimes resembling towards the picture of the retinitis pigmentosa. That's again one of the retinal degenerative changes that we've already discussed. You can see this is the clumping phenomena that is observed over here somewhere. And this clumping phenomena is quite visible in this kind of a picture. That is, if you see this kind of a picture of an after performing an ophthalmoscopy or after performing a fundoscopy, that would give you again the clues towards the retinal degenerative mechanisms that are occurring at the subretinal level, or they're occurring at the chorioretinal level, at the peripheral level, or at the macular level, depending upon the location of this clumping phenomena. Then we have the diffuse chorioretinal degenerations. So this diffuse kind of a picture is sometimes seen in a lot of individuals, in which we observe, in which we appreciate that this chorioretinal pigmentation, this degeneration is basically known, or it can be called as the it is occurring at the chorioretinal level. This pigmentary changes are occurring at the chorioretinal level. And again, one of the causative factors towards the development of this chorioretinal degeneration are the myopic individuals. The short-sightedness is again one of the causative factors towards the development of this diffuse kind of a picture in the chorioretinal degenerations. This is again one of the fundoscopic finding of the diffuse kind of the chorioretinal degenerations. Another variant is the peripheral cystoid retinal degeneration. Again, you like to appreciate the fact that this is a senile phenomena. This is age-related. Again, it's more common with the advancing age, this peripheral cystoid kind of a retinal degeneration. These cysts are again sometimes seen at the periphery. And sometimes the ERGs are performed in these individuals, or the advanced testing, if needed, they can be performed. The treatment guidelines, whatever the kind of a degeneration is, or whatever the kind of the syndrome that the patient is suffering from, that would be to treat the complications if there are any occurring in that particular individual. For example, if the retinal detachments are occurring, we can just focus on focal laser, or it can be even the grid lasers that are performed for these individuals, as well as the pars plana vitrectomies, that is the PPVs, can be performed to treat any cases of the complications, that is the retinal detachments, if they do occur in these individuals of any kind of retinal degenerations that we have already studied. Now, once we have covered the peripheral retinal degenerations, that can be involvement of it can be a picture of the snail tract, it can be the picture of the lattice work, the cystoid appearance, the retinoschisis if it is occurring at the periphery. All of these would be basically the subclassifications of the peripheral retinal degenerations. Then we have the other group, which is basically the vitreoretinal degenerations, that is involving the vitreous as well along with the retinal layers. The degenerations, the degenerative process is occurring at the retinal level, and so involving the vitreous as well. The complaints of floaters and the complaints of the flashes of lights are most common with this kind of the degenerative mechanisms that we study over here. The kinds of the vitreoretinal degenerations can be the Wagner's syndrome. Again, I would like to basically just emphasize on the fact that all of these conditions are congenital, they are hereditary. They can be autosomal dominant, or they can be autosomal recessive, as we'd be studying the most common ones, just the features of the most common ones. But over here, you would just keep in mind that all of these conditions are hereditary or congenital in their occurrences. The Wagner's syndrome is one of the syndromes in which the patient is hereditarily or congenitally suffering from the retinal degenerative mechanisms. Again, it's an autosomal dominant phenomena. The vitreous, the retina is involved. There are sometimes a cataract, and as the name is indicating, it's a syndrome. It's not an isolated condition. The patient is suffering from a syndrome, so he'd be having some of the coupling features as well. So this is the one of the syndrome that is associated with the vitreoretinal degenerations. Then we have the Stickler's syndrome. Stickler's is again autosomal dominant in its occurrence. Again, it's a syndrome. It's a complete picture that would basically give you, we'd be discussing the features of Stickler's syndrome furthermore, and we'd be just enhancing the fact that it's a syndrome. Along with the retinal degenerations, the vitreous is also involved. The vision is also affected. Obviously, the end result would be the decrease in the visual acuity in these individuals. Either it is the Wagner's, or either it is the Stickler's, or any other syndrome that is involving the retinal degeneration. Because retina is basically responsible for the end vision, or it is the end organ for the vision in the individual. So if it is suffering from degeneration, obviously the end picture would be the decrease in the visual acuity in these children. Then we have the Faber-Goldman syndrome. Patients usually having the Faber-Goldman syndrome are suffering from nyctalopia. So nyctalopia is basically the night blindness that you usually see, and that is in a lot of cases associated with the vitamin A deficiency. But over here, you would just observe that this is a coupling phenomena with all of the other syndromes. It's not the vitamin A deficiency that is responsible for nyctalopia and Faber-Goldman syndrome. It's the retinal degeneration along with the vitreous involvement that is responsible, and that is involving the cones, obviously. So the familial exudative vitreoretinopathy, it's again a familial condition. Then we have the erosive vitreoretinopathies. We have the dominant neovascular inflammatory vitreoretinopathies. So it can be an inflammatory condition. Sometimes it's without an inflammation, but sometimes this vitreoretinal degenerations, it's due to the causative factors of the inflammatory changes that are occurring on the underlying mechanisms. So this is one of the new vascularization is sometimes quite dominant in this kind of a variant. The dominant vitreoretinal choroidopathy, in which the choroidal plexus is also involved in these individuals, along with the vitreous, along with the choroid and the retina. All of these layers are involved in this kind of degenerative changes involving the vitreous and involving the retina. Just considering the vitreoretinal degenerations and what can be the pathogenesis or the underlying pathogenesis regarding the vitreoretinal degenerations, is this diagram is basically briefly explaining this. This is a normal retinal pigment epithelial cell in which you can observe the potassium channels are working in a normal manner. The inwardly rectifying potassium channel is almost 7.1 KIR, and the photoreceptor neuron is also closely in relation to these potassium channels. Just having a look at the mutated retinal pigment epithelial cells, you'd observe that the inwardly rectifying potassium channels are not quite occupied or positioned in a normal manner along with the photoreceptor neurons. So this abnormal localizations of this rectifying potassium channels is the basic causative factor for the development of this vitreoretinal degenerations, whatever the cause may be. It can be the hereditary problems that are occurring, or it can be the acquired conditions. These potassium channels are basically mutated, that is basically responsible for the development of the vitreoretinal degenerative mechanisms. Now, talking about the Wagner's syndrome, as we've already discussed, it's an autosomal dominant syndrome that is observed, and that is obviously related to the retinal degenerative mechanisms. There are these particular features for the Wagner's syndrome that you'd be studying. As you can see, the retina is basically the one of the layers, one of the protective layers that is indented or that is degenerated in these cases of the Wagner's syndrome on layman terminology, or just you can see sometimes this retina along with the choroid is affected, and sometimes after this retinal degeneration as a complication, there is this retinal detachment observed in a lot of individuals. So just giving you an overview towards the Wagner syndrome. Now, what can be the pathogenesis regarding the normal appearance of the cells of the extracellular matrix that is present in the retina? What are the kind of cells that are present in the extracellular matrix? It is the extracellular matrix proteins that are usually present over there, and then we have the versican isoform that is present, and then we have the versican isoform 1, 2, and 3. So these isoforms are basically the cells that are compromising or that are contentizing the extracellular matrix in the retina of the individual in a normal eye, in a normal person. If it is a mutated complete ocular cell, the extracellular matrix or the presentation or the arrangement of these vesicant isoforms would be quite mutated in these individuals. Even the extracellular matrix proteins are sometimes malpositioned in these individuals who are suffering from Wagner's syndrome. So over here, you'd observe that there are these typical features for Wagner's syndrome. It can be the vitreous is sometimes involved. It is liquefied in these individuals. Then we have the retinal veins and the arteries that are narrowed and sheathed in these individuals. The choroid is also affected. It is atrophied in these individuals. And then we have a congenital cataract that is also observed in these children. So these are the particular features of the syndrome that we were talking about. It's just not the retinal degeneration that is present. It's the presentation of the cataract along with the choroid, along with the vitreous that is being affected in these particular individuals. So these are the particular changes when we are performing the FFAs or the fundus fluorescent angiographies in these individuals. You would see that there are these particular changes also observed along with them. Then we have the Stickler syndrome. It's again one of the variant of the autosomal dominant kind of a variety that is seen. It's also known as the hereditary arthro-ophthalmopathy. As the name is indicating, it is hereditary. It is autosomal dominant in its nature. Arthro, it is basically referring to the fact that in this syndrome, the joints are also affected. Ophthalmopathy is basically there are particular ocular features in a person who is suffering from this kind of Stickler's syndrome. So these are these three major characterizations or three major classifications you'd keep in your mind when you're talking about Stickler's syndrome or when you're discussing Stickler's syndrome. The features would be particularly of a vitreous that is liquefied in these individuals. The choroid is also affected. The retina is also affected. The lattice degenerations are the particular features that are seen in a patient who is suffering from Stickler's syndrome. Glaucoma is one of the particular features that is seen in patients who are suffering from Stickler's. There are a lot of angiographies that are being contrast-enhanced angiographies are being carried out just to observe that there is some sort of a lattice work degeneration that is the underlying mechanism in the Stickler syndrome of the retinopathy, as you'd observe over here. Ectopia lentis, that is the lens is also malpositioned or dislocated in these individuals. So these particular ocular features, and there is a presenile cataract that is also seen over here in these individuals. So these are the lattice work degenerations or the pigmentary changes that are occurring at the choroidal level in patients who are suffering from this kind of a syndrome. The ocular features, the list of ocular features would include the vitreous being liquefied. There is syneresis, that is basically there is a detachment, retinal detachment being seen. Myopia is one of the features. Maybe it's the causative factor for the development of this retinal degeneration or retinal detachments. Then we have the pigmentary changes also seen in these individuals. Then we have the vascular sheathing phenomena seen in these individuals. We have the bilateral retinal detachments. Then we have the ectopia lentis, that is the lens is malpositioned or it is not properly placed. And then there is a presenile cataract. So these are the particular ocular features seen in patients of the Stickler's syndrome. The other features of Stickler's syndrome would include a flattened nasal bridge. There are particular orofacial features, that is a cleft palate, and all of these features are quite predominant in these patients. Maxillary hypoplasia. Then we have a cleft palate abnormality in these children, a high arched palate. Arthropathies are very common. It would be the painful joints, the swollen joints, and then the hyperextendable joints. This would be the complete list of the arthropathies in this that is encompassing in the Stickler syndrome. Deafness is also associated with this kind of syndrome, and then the mitral valve prolapse or the MV prolapse is also seen. Another variant is the Favre-Goldman's syndrome. It's one thing to remember, it is the autosomal recessive kind rather than the autosomal dominant kind. The normal S-cone cells are like this, they're placed like this. We have the M-cone cells, we have the L-cone cells. The S-cone cells are the blue-violet light, they're recipients for the blue-violet light. The M-cone cells are recipients for the yellow-green light, and the L-cone cells are recipients for the yellow-orange light. The nuclear receptor NR2E3 is the gene product, and basically a ligand is also attached over there, and that is responsible for it. In cases of the mutated S-cone cells, they are not working in a proper manner, so we have this blue-violet that is affected, the cone cells that are responsible for the blue-violet light interpretation that are being affected in these patients of the Favre-Goldman syndrome. So the Favre-Goldman syndrome, just to remember the features, obviously the retina, vitreous, they're also affected. There would be the sheathing of the retinal arteries and the vessels that is noted down in these individuals. And another very important feature that is associated is the nyctalopia due to the S-cones that were affected. The pathogenesis was due to the mutation of the S-cones in these individuals. That would basically result in the nyctalopia or in the night blindness in these individuals. So the vitreoretinal sheathing is also affected, and again, it would be a autosomal recessive kind of disorder that we talked about. So in this particular lecture, we just summarized briefly the different hereditary and the acquired conditions that are responsible for the retinal degenerative mechanisms in an individual. We classify these retinal degenerations on basis of periphery or centrally located. Whatever the case may be, the complications are out there, so it's very important to have all of these differential diagnoses in our mind whenever we have a case of retinal degenerations, and we should know what are the particular management or the treatment guidelines out there available for these people who are suffering from such kind of syndromes or such kind of conditions. So that is the end of this lecture. Thank you for watching sqadia.com.